Thank you for the honor of addressing this group. Accelerants are highly flammable substances used to intentionally start a fire. Forensic investigators who suspect arson look, among other things, for traces of these chemicals. Residual unburned traces turn an accident investigation into a crime scene. Let's examine some of the demented acronyms that increasingly dominate our lives. Let's view them as accelerants, fueling the wildfire of burnout and associated moral injuries through our community. I have no disclosures. Burnout describes clinician distress in an inherently dysfunctional system. It arises from excessive demands in the workplace and leads to a feeling of emotional exhaustion. There are innumerable references documenting burnout in various clinician populations around the world. But the very term burnout seems to imply that we were just stronger, smarter, better, we wouldn't burn out. We'd like to think that surgeons do not burn out. Yet the very nature of our work and our ethos in the current environment predisposes us. We take on tough cases and expect excellent outcomes. We suffer, find workarounds, and continue to advocate for our patients until the burden becomes unendurable. The very dedication and perfectionism upon which we surgeons pride ourselves may render us more susceptible. Failure to recognize the symptoms, to name the problem, leads to a delay in intervention. Burnout is a symptom of a problem in the workplace, not a weakness of the clinician. Burnout and disruptive behavior are on a continuum. When too much pressure has accumulated over time, the clinician erupts. At the breaking point, surgeons may consider early retirement from surgery. Clinical depression is common, and suicide may be an extreme consequence. Moral injury results when a clinician knows what a patient needs but cannot provide it because of external constraints. Bailey in the Washington Post cited a business model that interferes with patient care. Surgeons are smart, tough, durable, and resourceful. If we could have MacGyvered ourselves out of this situation by working harder, smarter, or differently, we would have done it. In fact, our constant efforts to MacGyver ourselves out of one or another bind and to get the care our patients need may have contributed to our ever-growing burden of burnout and moral injury. Let's name some of the accelerants that are fueling this fire. The electronic health record, now available 24/7 on your computer or smartphone, devours an increasing amount of physician time. This causes a time crunch, which increasingly occupies evenings and weekends and other off hours. Clinic encounters center around a computer terminal, with the physician frantically clicking boxes rather than actually talking with the patient. Precious time between OR cases is eaten up by computer order entry and documentation, rather than a much-needed drink of water. This fuels an increasing sense of depersonalization that affects both the physician and the patient. And of course, all of this is occurring in the background of COVID-induced disruptions in care, patient flow, and diminishing reimbursement. The expense of the electronic medical record itself is an additional insult. Dr. Danielle Ofri, an attending physician at Bellevue Hospital, published an editorial in the New York Times with the inflammatory title, "The Business of Healthcare Depends on Exploiting Doctors and Nurses." Noting that the ethic of medicine is being cynically manipulated, She goes on to confirm and articulate the ever-increasing burden of data entry. By now, corporate medicine has milked just about all the efficiency it can out of the system, she wrote. One resource that seems endless and free is the professionalism of caregivers. Noting the failed promise of the electronic medical record, Dr. Atul Gawande went on to comment on the use of scribes. He said, "This fix is admittedly a little ridiculous. We've replaced paper with computers because paper was inefficient. Now computers have become inefficient, so we're hiring more humans. We are, in effect, MacGyvering around the system." Silverman, in another New York Times editorial, logged onto a new EMR system for the first time to be greeted by this message: "You currently have deficiencies that are either delinquent or will become delinquent within 1 week." Deficiencies the first time you ever sign in to a chart? Before even logging a single patient? Numerous studies document pervasive infiltration throughout the medical subspecialties and suggest that the burden falls heaviest on younger physicians and female doctors. This is one area where we, as surgeons, are not alone in feeling pain. Wright quotes an internist as saying, "At the highest level, we are disconnected from our purpose and have lost touch with the things that give joy and meaning to our work." Adding even more volatile fuel to the fire, as reimbursement has decreased, surgeons are forced to do ever-increasing volumes of less and less well-paid procedures to hit productivity targets. This affects surgeons who are employed by corporate entities and those who run their own small businesses. For anyone early in their career, I strongly recommend the SAGE's manual on transition to practice. You need to know about these things. RVUs are a measure of value used in the reimbursement formula for physician services. Every procedure, every encounter generates one or more cluster of CPT codes, which then determine payment. It's a lot more complicated than that, but here is the heart of the problem for surgeons. Not all surgical specialties are reimbursed at the same conversion factor, and the RVUs assigned to a procedure actually correlate poorly with complexity, duration, or risk. This study by Gann et al. Documented lack of correlation in urological procedures. And this study by Shaw et al. Showed similar problems in surgical oncology. They concluded for common index general surgery procedures, the current RVU assignments poorly correlate with certain metrics of surgeon work. Given the increasing emphasis on measuring and tracking surgeon productivity, more objective measures of surgeon work and productivity should be developed. This is not just a wildfire, this is arson. Traces of the accelerants are obvious. If our hospitals and our practices and we ourselves are to survive with our humanity intact, we must find better solutions. As advocates for our patients, we must speak out, not just for ourselves, but for the young surgeons like these University of Iowa chief residents who are our future. Thank you.